Welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SF Derm experience.
Without further ado, I'd like to invite up Dr. Haley Naik, who's an associate professor at the University of California, San Francisco, and a true expert in hidradenitis. So thank you so much. I want to start out by just sharing kind of my overarching strategy for managing HS, which is first and foremost using medical therapies to control the inflammation associated with HS. And then second, and only after inflammation is well controlled, sending my patients to one of our esteemed surgeons to help with removing the irreversibly damaged and disfigured tissue. And so we're going to talk about controlling inflammation in HS using biologics. I want to first kind of touch on when, because this is a question that we get a lot. When do you start a biologic? When do you know that it's time to start a biologic? And I think, the biologics that I'm going to be talking with you about, they are either FDA approved for moderate to severe HS, or, we tend to use them for moderate to severe HS. But one question that comes up a lot is, what is moderate to severe HS? And I think one of the ways that we've thought about this is by using Hurley staging, which is kind of outlined here on this slide, where stage 1 is characterized by nodules and abscesses with or without scar. Stage 2 is characterized by nodules and abscesses with tunnel formation, previously called sinus tracts or fistula, and scar. And Hurley stage 3 is characterized by all of the above, but the tunnels in this stage are interconnected. And historically, we've said moderate to severe disease is Hurley stage 2 or Hurley stage 3 disease. And I'd like to posit that we really need to completely shift the way that we think about moderate and severe HS and categorize this disease. And I'll give you an example of acne. When we think about acne and when we talk about or make a decision to start isotretinoin for our acne patients, one of the main goals of that therapy is to prevent the development of scar. And so I would suggest to this room that what we should be thinking about when we're thinking about biologic management for HS is preventing permanent disfigurement and destruction of tissue. And so we can think about starting biologics as early as Hurley stage 1 with scarring, and patients who may not have tunnels yet, but already have disfigurement from their disease. And I call that moderate disease for sure. So these are the targeted therapies we're going to be talking about: TNF inhibitors, IL-17 inhibitors, and JAK1 inhibitors. But before I talk about each of these categories of targeted therapies, I want to address the question of how are we going to get these medications approved for our patients, which is kind of one of the biggest hurdles today in getting our patients access to these drugs. And I want to share with you these prior authorization templates that are available on the HS Foundation website that Dr. Alishin has spearheaded and championed and helped develop and revised this last year to make sure that all the updated data is included in them. Each of these letters, which you can just add your patient's name to and print out and send off to insurance companies for prior authorization, have 15 to 30 references associated with them. And so they're really kind of well-founded, high-impact letters. And I have to say that I use them in every HS clinic, and I've had great success getting medications approved for my patients. So I'm going to just, this slide will come back again later, but I want to make sure that you all know that these medications are available, not just in theory, but in practice for your patients. So starting with TNF inhibitors, this is an oldie but a goodie, the first one really. The first FDA-approved drug for HS was Adalimumab, and these are data from the landmark pioneer studies that used and showed that Adalimumab 40 milligrams weekly was superior to placebo, and about 50% of patients responded to this therapy. But response in this trial and in subsequent trials has been defined as 50% improvement in abscesses and nodules without an increase in abscesses or tunnels. And I think while we can all agree that Adalimumab did a world of good in breaking open this field and breaking open therapies for HS, practically speaking, 50% improvement in abscesses and nodules is probably still not very satisfactory for our patients. So what are the real world goals of medical therapy? I would say that real world goals in our clinical practices for using medical therapies and biologics specifically for HS is to reduce pain, reduce the symptoms, the burdensome symptoms of HS. I always tell my patients when I start you on this biologic, my goal is that these meds or this particular medication will stop new HS lesions from developing, and that's really the goal I'm trying to reach with this biologic. You may have improvement in the frequency and the pain and the recurrence of these old HS lesions, but those are lesions we're probably going to manage with surgical therapy. The goal of this biologic is to stop new lesions from forming. So again, what does response look like? In my book, complete response means no pain, no new lesions, and maybe you might have recurrent lesions. But if you come back to me in follow-up, my expectation for this medication is that you will not be developing new lesions, and in that setting, I will continue you on that current therapy. However, if you come back with a partial response, which in my book means your pain is improved, but it's not gone, you have a reduction in the number of new lesions that are developing, but you might still be developing new lesions, and your recurrent lesions are continuing to recur. In that setting, maybe that medication has helped some and we need to increase the dose, or maybe we need a change in therapy. So kind of in this scenario, what do you do when your patient comes back in 3 months with a partial response to Adalimumab 40 milligrams weekly? Now that Adalimumab is off patent, it is much easier to get 80 milligrams weekly approved for patients with Dr. Alishin's beautiful prior authorization templates. So that's one option. And then another option, the name of the game here is high dose, high frequency infliximab as a next line therapy for HS. And that is really what's required for HS management. This is before and after images of patients on infliximab, and you can see high dose, high frequency infliximab, and you can see that there's substantial improvement in HS. And I think the point that I want to make on this slide showing you this figure is that no matter where you start your HS patients, most patients will require high doses and high frequencies of infliximab in order to get their HS under control. And what we're talking about is doses at 7.5 milligrams per kilogram and higher, dosed every 4 to 6 weeks. And to help manage and prevent the development of anti-drug antibodies, methotrexate 7.5 to 15 milligrams weekly plus folate daily is a good kind of regimen to use. So the clinical pearls for TNF inhibitors for HS. Again, infliximab, despite all the therapies that we currently have, infliximab remains the single best biologic for moderate and severe HS. Higher doses and increased frequencies are required. And as Dr. Barnes said, it's important to bring your patients back pretty frequently to tweak their therapeutic regimen, escalate their dosing to try and work with them to achieve a complete response, as I defined earlier. You can use methotrexate, and for patients who can't get methotrexate for various comorbidity reasons, azathioprine is another option for preventing anti-drug antibody formations. And when anti-TNF stop working, the things I try are to try a course of broad-spectrum antibiotics to reduce the bacterial burden and help the anti-TNF continue to work for your patients. I check for anti-drug antibodies, and I may start or increase methotrexate or azathioprine. And then, of course, the other option is to transition agents. I'm going to end with just a couple pearls, kind of summarizing this talk alongside Dr. Alishan's talk. I think it's really important to recognize that as yet, we're still not quite at a place where all of our patients are going to be adequately managed on monotherapy, a single agent for their HS. So when we're taking care of our HS patients, we do need to think about layering these therapies. And I liked Dr. Barnes' suggestion of staggering when you start these therapies to help patients get used to these medications and make sure that we're helping them identify any side effects and really appropriately attribute those side effects to the right medications. But really thinking about adding a hormonal therapy or a biologic or an antibiotic to a biologic are ways that we can think about layering therapies for our patients. And then I want to circle back to this idea of making sure that patients are optimally clinically managed, medically managed with medical therapies before we send them to our surgical colleagues to remove irreversibly damaged tissue. My take-home points are the following. HS inflammation is robust and really requires aggressive and early management, and really thinking about when you start therapy for these patients at the first sign of scarring and permanent disfigurement. Closely monitoring these patients and dose escalating biologics is key to using biologics effectively for HS. Layering HS medical therapies is another important key to taking care of these patients. And then just to beat a dead horse, optimizing medical management of HS prior to sending patients for surgery.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.